In this video, we'll discuss about modified Widman flap. The question will be asked like this. Define and classify periodontal flaps and write in detail about modified Widman flap. Very much important long essay. So the definition of periodontal flap is nothing but a section of gingiva and or mucosa that is reflected from underlying tissues surgically. Why it is reflected? To provide visibility and access. This is the very much important term. Visibility and access to the underlying bone and root surface. Right? And it also provides the chance to displace the gingiva to correct mucogingival problems. That means if there is dehiscence or if there is penetration, right? Or if there is gingival recession. So in those cases you can go for displacement of the gingiva. So this is the definition of periodontal flap. And then coming to the classification, there are three criteria to classify the periodontal flaps. The first one is bone exposure after the reflection. Based on that criteria, it is divided into two. Right? There are three criteria. In each criteria, there is two type of periodontal flaps. So based on bone exposure after reflection, is it full thickness? That is mucoperiosteal flap. That means bone is directly exposed after the elevation of the flap. Complete mucosa or gingiva along with the periosteum is elevated. You can see in this diagram, this black colored one is nothing but the tooth and this is the bone and this is the flap elevated. You can see you have the direct access to the bone. That is the full thickness flap. And partial thickness or split thickness is nothing but the elevation of the epithelium and some amount of connective tissue. Not complete exposure is not there, right? In this diagram you can see here, there is elevation of the epithelium and connective tissue, right? And there is some amount of connective tissue along with the periosteum is still covering the bone. That is partial thickness, split thickness flap. So full thickness flap is indicated when you want to do the osseous surgery. That means if you want to do something on the bone, then you have to go for full thickness flap. And in partial thickness flap, if you want to displace the flap apically, right? Or if you want to avoid if there is chances of fenestration or dehiscence, right? In those cases also you will go for partial thickness flap. And second criteria is placement after surgery. Is it non-displaced or displaced? Non-displacement is nothing but the flap is returned to its original position and sutured. Right? In this case, this flap, elevated flap, if it is returned here and sutured, then it is called as non-displaced flap. Example, modified Widman flap. For displaced flap, you can displace this apically or coronally or laterally. Right? In this case also, in this diagram, you can see here, this is the apically displaced flap. This elevated tissue, elevated flap is displaced apically, or you can displace it coronally, or you can displace it laterally. Right? In this case, it is displaced apically and sutured here. So apically displaced flap have double advantage. It eliminates the pocket, one thing, and second thing is it converts the pocket lining into the attached gingiva. That is very much important. Right? It increases the attached gingiva. That is one of the most important PZ bit, apically displaced flap. So this is one criteria. And third criteria is nothing but the management of the papilla. Based on that, is it conventional flap or papilla preservation flap? Conventional flap is nothing but the papilla is severed below the contact point. And it is, that means buccal interdental papillas are reflected on buccal side and lingual ones are reflected on the lingual side. You can see in this diagram. These are the teeth and this is the buccal flap elevated and this is the lingual flap elevated. This is the buccal interdental papillas. These are the lingual interdental papillas. Right? This is conventional flap. And in papilla preservation flap, entire, that is complete, both buccal and lingual interdental papillas are reflected in one flap. Right? In this case, you can see here, this is the buccal flap and this is the lingual flap. This one is nothing but the lingual flap. Right? So you have to take both clavicular incision and horizontal incision on the lingual side. So if you see, this is the lingual interdental papilla, then you have to take a horizontal incision like this, and you have to completely elevate the flap on the buccal side. You can incorporate in the buccal flap or lingual flap. Right? This is papilla preservation flap. So based on these classifying categories, the modified Widman flap is full thickness flap, non-displaced, right, and it is conventional flap. Now we will discuss about modified Widman flap. Modified Widman flap is given by Ramford and Nisse. Right? It is modified because there is differences between original and modified. In original, bone exposed is 2 to 3 mm. In modified one, it is minimal. Because there is large bone exposure in original case, so you can go for infra-bony defects, or bony recontouring can also be done by original. That is not possible in case of modified, or not generally done in case of modified. Right? Because there is large amount of bone exposure, there is post-operative resorption of the bone in case of original, which is minimized in the modified. And vertical incisions also taken in the original one. There is no need of vertical incisions in the modified one. Modified Widman flap is essentially a envelope flap. Right? Then the original is pocket elimination procedure, whereas modified Widman flap is a pocket reduction procedure. Right? Pocket reduction means the reduction of the pocket occurs by tissue shrinkage after the procedure. Right? So, coming to the objective, why you are doing modified Widman flap or any flap surgery, the main objective is to provide visibility and access to the root surface, to facilitate instrumentation, that is to do the curettage, complete granulation tissue removal and scaling and root paling. Because if there is continuous presence of granulation tissue, that will act as a nidus for the progression of the periodontal disease. So to prevent periodontal disease progression, the surgical treatment is nothing but the removal of that granulation tissue or plaque or calculus that will act as the nidus for the microorganisms. How you can remove that? You have to gain access to the root surface. How you can gain access? You have to elevate the flap. Right? That is what you are doing in the periodontal flap. Right? So another objective is to remove the pocket lining also in the modified Widman flap. So coming to the indications, it is indicated in cases of aesthetic region, especially in the cases of maxillary anterior sextant. Right? Or you can do anywhere, but especially indicated in cases of maxillary anterior sextant. Right? And deeper pockets, when there is 5 to 7 mm of pockets. These are the some of the indications. Contraindications, bony defects that need to be recontoured or regenerated. That means if there is negative architecture of the bone, right, due to the severe periodontal disease, in those cases you have to go for the bony recontouring. But that is not possible with the modified Widman flap. Or if there is uncontrolled systemic disease, right, or if the patient is not motivated to exhibit good plaque control, in these cases it is contraindicated. Then coming to the advantages, it provides access to the root surface, right, and there is good adaptation of the tissue to the bone, so that there is good healing after the procedure. Because of that healing only, pocket depth reduction is occurring. Right? Then coming to the disadvantages, you can't go for bony surgeries, that is osseous surgery, correction of the any bony defects can't be possible, and it is not essentially a pocket elimination procedure, it is a pocket reduction procedure. Those are the two disadvantages. Now we will discuss about surgical procedure in detail. Procedure can be done under local anesthesia. Based on the area of operation, you have to go accordingly. That is type of nerve blocks, right? After LA, the first incision is internal bevel incision. It is also called as reverse bevel incision, which is made 0.5 to 1 mm away from the gingival margin. Very much important. This is PG bit, right? So in this case, you can see here in this all these diagrams, green colored one is nothing but the bone, and red colored one is nothing but the flap or gingiva, and these blue colored ones are nothing but the granulation tissue or calculus, right? So in this case, this is the gingival margin. From this gingival margin, your internal bevel incision is 0.5 to 1 mm away, like here, right? So this will start here and it will be directed towards the apical side, that is towards the crest of the interdental bone. That is the important one. In gingivectomy, the bevel of the blade is towards the coronal side. That is, it is directed towards the coronal aspect. But in case of flap or modified Widman flap, it is directed apically. That is, it is aiming towards the crest of the bone, interdental bone. That is why it is called as reverse bevel incision. Internal bevel incision can be asked for very short answer question also, 2 marks question, right? So your first incision starts here, right? It starts here and it is aimed towards the crest of the interdental bone. So this is the internal bevel incision. With this incision, you can elevate the flap, right? That means the remaining thing, you have to leave this one and you have to elevate the remaining flap, that is full thickness mucoperiosteal flap. You can see here in this diagram, right? So after internal bevel incision, after that you have to elevate the flap, right? You can see in this diagram I have elevated a flap. After flap elevation, make sure that only the limited amount of bone is exposed or it is elevated. If you elevate too much of flap, there will be post-procedural resorption, bone resorption, right? That is the one of the difference between original Widman flap and modified Widman flap. In original Widman flap, almost 2 to 3 mm of the bone is exposed. But in modified Widman flap, it is only some amount, or if you see the crest of the bone, then it is enough, right? After that, clavicular incision. Clavicular incision is nothing but the from this aspect. That is, this incision is into the gingival crevice, right? So this is your clavicular incision. It is also directed towards the crest of the interdental bone. So with the internal bevel incision and clavicular incision, you are going to have the V-shaped tissue, right? This one. This is the gingival collar which is left after internal bevel incision and clavicular incision. So the third incision is nothing but the interdental incision, right? This interdental incision is directed perpendicular to the tooth surface or perpendicular to the bone. So it will be here, right? So the aim of this is to detach this V-shaped gingival collar from the underlying bone. And we have to completely remove this gingival collar. Very much simple. If you remember these steps, then it is enough. Internal bevel incision, clavicular incision and interdental incision, right? So after removing gingival collar on the buccal aspect, you have to repeat all these procedures on the lingual aspect. Simple. On the lingual or palatal aspect. You can see in this diagram. In this diagram, this red colored one is nothing but the flap elevated and green colored one is the exposed bone. So after flap elevation, you can see here, these blue colored dots are nothing but the granulation tissue or calculus, right? And due to the periodontal disease, there is some amount of bone loss also. Some roots are exposed or mild furcation involvement also there, right? So this procedure should be repeated on the palatal aspect or on the lingual aspect. You can see in this diagram, this is the flap elevated on both sides. That is on the buccal side, this is buccal side, and this is the lingual side. Right? Once you develop flap, once you elevate complete flap on both sides, then you have to go for granulation tissue removal and scaling and root planing. This is the main step in the flap. Any flap procedure, the success of flap surgery depends on the complete removal of the granulation tissue and scaling and root planing. This is very much important step. This is the most important step, right? That means with curettes and ultrasonic scalers, you have to completely remove these all interdental granulation tissue or granulation tissue on the presented on the buccal side and lingual side. Complete blue colored ones should be debrided, right? That means complete granulation tissue should be removed. Once you remove complete granulation tissue, there will not be any bone, any bleeding from the bone or on the bone. Bone should be completely white and it should not have any bleeding spots. If there is bleeding spot, means there is granulation tissue left there, right? You can see in this diagram, bone, whitish bone should be visible, right? And there should not be any bleeding. This is the main indication that if there is no bleeding, then there is no granulation tissue left. That is the main success for flap surgery, right? So after granulation tissue, what will you do? You have to adapt the flaps again, right? We have to adapt the flap, and if necessary, you can thin the flap also, right? With the scissors and like that. After that, you have to go for suturing. In suturing, continuous sling suture should be placed. Continuous sling suture. For example, so these are the teeth, right? I will show continuous sling suture here. These are the teeth, and this is the flap. This is the interdental papilla, and this is the interdental papilla, and this is on the lingual side, right? This is the flap, simplified one, right? So when you are doing continuous sling suture, start posteriorly. First, I will engage this. This is the buccal side and this is the lingual side. I will engage interdental papilla between the first and second molar on the buccal aspect, right? I will take a bite through this interdental papilla, right? And I will go from the interdental space to the lingual side. So lingual side, I will not engage any interdental papilla. I will just go around the first molar like this, right? Like this, and I will come on to the buccal side. I did not engage any interdental papilla on the lingual side, right? So I will again come on the buccal side, and I have to reverse the direction of the needle, and I will engage the interdental papilla between the second premolar and first molar. When you are coming on the buccal side, I will not engage. I am not engaging, right? I will redirect it like this, and I will engage this flap now. After that, I will go lingual, right? And I will again make a sling around the second premolar like this, and I will come on to the buccal side. When you are coming buccal side, you should not engage. You should reverse it backward. Then you should engage this interdental papilla, right? And again I will go on the lingual side. It continues like that, right? So if there is here also one papilla, I will reverse it and I will engage it, and I will come on to the lingual side, right? So in lingual side also, buccal side all engaged. Now we will start on the lingual side. I will reverse it and I will engage the lingual tissue here, lingual interdental papilla, right? And I will make a sling around the tooth, and I will go lingually, and I will reverse it and engage the interdental papilla, then make a sling, right? It goes on like that, right? It goes on like that. So again you have reached from where you have started, right? This is the interdental papilla. I have started and there is one end here and again another end. You should make a knot. This is continuous sling suture, which is recommended in flap surgeries. And one more important thing is there should not be any bone exposure. You should completely cover the bone with tissue. That is important thing, right? And after that you should place the periopac. When you are suturing the interdental papilla also, you can see in this diagram. So interdental papilla forms a triangle, right? In this case you can see here, this red colored one are nothing but the interdental papillae. So in interdental papilla you have a triangle like this and the base of the triangle is here, right? In this case also this is the triangle, this is the triangle. So you should always engage the interdental papilla below this base of the triangle, right? You should engage below this base of the triangle. For making internal bevel incision and clavicular incision, you can use 11 number or 15 number or 12 number blade, right? 12 or 12D blade, right? But for interdental incision, you have to use Orban's knife. Otherwise, you can simply do it with a curette also. Just you have to remove this gingival collar. And after suturing, you have to place the periopac. Periopac is again a very short answer question, important question. We will discuss in a separate video. But in this case, you can see here, right? Buccal side, this red colored one is nothing but the periopac. It is turned around the last molar and it is placed on the both buccal and lingual side also. If you see it from the buccal aspect, it will be covering cervical third of the tooth, right? Cervical third of the tooth and attached gingiva. It will be placed like this, periopac, both on the buccal and lingual side, right? So this is the step-by-step procedure. You have intraoperative bleeding, that is due to the granulation tissue, and second, post-operative sensitivity because of the exposure of some of the root surfaces, right? And third is continuing disease progress, right? Continuous periodontitis. If you fail to remove complete granulation tissue, complete calculus plaque, right? If you fail so, then there will be continuous progressing periodontitis, right? This is all about modified Widman flap. If you like this video, hit the like button, share the video, subscribe the channel.